Hi, my name is Amanda Winters, and I am an assistant professor of pediatrics at the University of Colorado Anschutz Medical Campus. I practice at Children's Hospital Colorado in the Center for Cancer and Blood Disorders, and my clinical and research specialties are acute myeloid leukemia, or AML, as well as myelodysplastic syndromes, which are premalignant diseases of the bone marrow that, if untreated, typically develop into AML. Today I'm going to share one of the research projects with which I'm involved, the utilization of a special type of PCR called Droplet Digital PCR to measure residual disease in AML. As a bit of background, I want to briefly look at the outcomes for both adult and pediatric AML in this country. People of all ages get AML, but the incidence typically increases with age. Children and teenagers with AML seem to have a different kind of disease from adults, which is somewhat easier to treat. That being said, AML at any age is a challenging diagnosis, and many patients, often despite receiving quite aggressive and highly toxic chemotherapy, will relapse within 5 years of their initial diagnosis. In pediatric patients, this relapse will occur in about 1/3 of people. In adults, at least 1/2 to 2/3 of patients will relapse. It is these cases of relapse that we want to try to prevent, in part by developing more sensitive and specific methods for detecting residual disease. There is quite a bit of literature to suggest that a positive test for measurable residual disease, or MRD, helps us risk stratify patients in a far more accurate way than just the presence or absence of morphologic remission, as determined by a pathologist and a microscope. Clinically today, the vast majority of MRD testing is done via flow cytometry, which describes immunophenotype of cells and allows detection of 1 in 10,000 leukemia cells, usually by identification of 2 or more proteins that are never expressed together on normal cells. On the left is a figure from a paper illustrating persistent MRD in a patient who ultimately relapsed, the time course on the top, and slow disappearance of MRD in a patient who went on to have long-term remission, the time course on the bottom. The figure on the right is from one of more than 20 papers that describe different cohorts of patients for whom MRD has consistently proven to be predictive of relapse-free survival. So why mess with a good thing? Well, especially in AML, cell surface markers can change over time, particularly after leukemia cells have seen chemotherapy or immunotherapy. This makes it difficult at times to distinguish a malignant white blood cell population from a variety of normal ones. A far more reliable way to detect MRD is to measure abundance of leukemia-associated mutations, which are not present in normal cells. This is done in other diseases, for example, measurement of BCR-ABL fusion transcripts in chronic myelogenous leukemia by PCR-based methods. We decided to use a sensitive version of PCR, or polymerase chain reaction, to measure AML-associated mutations in bone marrow samples from patients on therapy. Just as a quick overview, Droplet Digital PCR, or ddPCR, is very similar to quantitative PCR, except that the PCR reaction is emulsified into individual droplets by combining with oil. Individual copies of DNA template are then captured in each droplet, along with the reaction components needed to amplify the gene of interest. Fluorescently tagged probes in different colors for the normal or wild type and mutant versions of the gene are used to identify the respective DNA strands in each droplet. The fluorescence of the droplets can then be measured and used to calculate abundance of the mutant DNA. This technique is highly sensitive, can detect one mutant gene copy in 10 to 100,000 copies. It is at least as sensitive as flow cytometry and often much easier to interpret. Our lab has validated over 60 mutation-specific ddPCR assays for this AML project. Most of them were designed by us, but some are commercially available. As you can see from the table, most of the assays detect recurrent mutations that are seen in many patients with AML, but a few were designed specifically with a single patient's needs in mind. Here I'm showing you a waterfall plot of individual mutations in 22 AML patients enrolled on a clinical trial. The down-pointing bars show the drop in abundance of the patient's specific mutations from diagnosis to best therapy response, with -100 indicating complete disappearance of the mutations, what we call MRD negative. These mutations are the ones marked with asterisks. Anywhere between 1 and 4 mutations were monitored for individual patients. 4 patients, shown in green, became MRD negative for all mutations and, as of our publication, had remained in remission at an average of 2 years. One has subsequently relapsed. The patients on the far right, in red, all remained MRD positive for at least one mutation, and all progressed or relapsed. The patients in blue also remained MRD positive by ddPCR, and yet had not relapsed as of publication. 5 of these 11 patients went on to have a bone marrow transplant, and in fact, all of them became MRD negative by ddPCR post-transplant. 3 patients, all elderly, died in remission. 1 patient has subsequently relapsed, leaving only 2 who remain alive and in remission with positive MRD. They continue to be monitored every few months. Since our publication describing these 22 patients, we have tracked these plus another 28 patients receiving the same combination of experimental therapy. MRD persistence consistently predicts poorer relapse-free and overall survival compared to patients who become MRD negative. We have also demonstrated the same correlation between MRD status and outcomes in patients post-transplant, when MRD is measured either from the day 28 or the day 80 post-transplant bone marrow. All of the data that I've shown you today have been obtained from adult patients with AML. Pediatric patients with AML have some overlapping mutations with adults, but for the most part have chromosome translocations, which adults do not tend to have. An important next step in my research is to design ddPCR assays for these translocations as well, so that we can more reliably monitor disease in pediatric AML patients. Thank you for taking a few minutes out of your day to learn more about the research going on through Children's Hospital Colorado and CU Anschutz. This research was funded by St. Baldrick's Foundation, Cancer League of Colorado, Swim Across America, and Drs. Teru and Bill Hayes. I thank these organizations and individuals for their generous support, and I thank you again for your attention.